Assalamu alaikum warahmatullahi wabarakatuh. Welcome in my training video. Our subject today is iron poisoning. Iron poisoning is most commonly in child as accidental ingestion. In adult may occur as a suicidal attempt. May occur in blood transfusion, especially but this is called chronic poisoning. In alcoholic patient or hepatitis C may occur. May the iron may be found in form of multivitamin like candy. Iron form the ingestion of elemental iron. We always collected iron, elemental iron. The iron in form of iron salt. Three main salt is important: ferrous fumarate, gluconate, and sulfate. And most important is ferrous sulfate. One tab contain 60 milligram elemental iron. Iron related dose toxicity. If the child ingested more less than 20 milligram per kg, it is not toxic. Only need 6 hours observation then discharge. If ingestion more than 20 to 60 milligram, may be mild to moderate toxicity. More than 60 milligram is severe toxic, may be lethal. More than 120 milligram may be lethal. Iron level. We sent iron level for patient at 4 hours after ingestion, and if the patient ingests slow release, we also repeated serum iron at after 8 hours. Normal level of iron from 50 to 150. If toxic level 350 to 500 is toxic, and more than 500 is lethal. Regarding total iron binding capacity, what we mean with total iron binding capacity is transferrin is connected to iron. When iron arrive to this level, transferrin no more connect to iron, so the iron become free in the blood and may go to liver and damage, work only in mitochondrial and make mitochondrial dysfunction, lead to decrease all function of mitochondria and decrease ATP. So an activated or anaerobic pathway will activate it, lead to lactic acidosis. Regarding stage of toxicity, we have 5 stages of toxicity. First stage is stage 1, called KIT stage, because the iron is corrosive, so it may cause ulceration, perforation, vomiting, diarrhea, abdominal pain, maybe cause shock, dehydration. This is the first stage. It may last 6 hours. If the after 6 hours, if the patient come within 6 hours, no any symptoms, we can discharge patient. And stage 2 is a recovery stage from EIT symptoms. All EIT symptoms is appear, and patient showed improvement. This stage may continue for 24 hours. If not treat good, patient will pass to stage 3. Stage 3 is systemic manifestation. Systemic manifestation may come with shock, metabolic acidosis with high ion job, dehydration, lactic acidosis. This stage may continue 3 days, within 3 days. After that, the patient pass to hepatic stage or hepatotoxic necrosis, lead to fulminant hepatic failure. within 4 days تقريبا, and patient may have transplantation of liver. And lastly, if the patient alive live may pass to 5 stage. The 5 stage is called also GIT stage, the scarring which occur by erosion of iron is heal. Heal by scar, then obstruction, maybe pyloric gastrointestinal obstruction. This is the last stage. Main important in manifestation is very iron in blood, which cause many damage, multi-systemic organ failure, maybe cause CNS, coma, seizure, lethargy, hepatic failure, and on blood because increased permeability lead to shock, and also may cause coagulopathy and a lot of pulmonary edema, renal failure. Many systemic may be affected by free iron in blood. Uh, what is the management? How can we deal with the case? The management, when patient arrive to ER, patient we should consult poisoning control center to give uh, their opinion. We don't forget to stabilize the case, airway, breathing, circulation. Then order X-ray. X-ray maybe show radio-oblique pills, and we order investigation like KFT for renal injury, LFT for hepatic injury, pocket glucose because patient may have hypoglycemia or hyperglycemia, blood gas patient may has an aerobic anion high anion gap acidosis. We CBC to roll out infection, prothrombin time, partial thrombin time, INR for coagulopathy. Then decontamination. And decontamination of the patient is vomiting. Induced vomiting is correct? No, it's wrong to induce vomiting. Gastric lavage. We do gastric lavage. Okay, if the patient arrive in within first hours and patient give history of ingestion more than 40, like this, or severe symptoms. If the symptoms is too severe, like acidosis and renal injury, hepatic liver enzyme, may need activate may need gastric lavage. Activated charcoal. Is any role for activated charcoal? Activated charcoal is no role in treatment of iron because activated charcoal is poor absorbed to iron. So only give if the patient have co-ingestant like iron and multivitamin or co-ingestant, we can use activated charcoal. Procedure of choice for iron toxicity is full bowel irrigation. How can do we this? By nasogastric tube with polyethylene glycol, well later in adult, 20 to 30 ml per kg per hour. The procedure may continue for more than 5 hours. What about antidote? Antidote need to opinion of toxologist. Need the antidote for iron is deferroxamine. Deferroxamine is drugs bind to iron and form iron to ferroxamine, which is water soluble, which is excreted in urine. Not all patients need deferroxamine. Only patient with heavy ingestion, or patient with serum iron high more than 400, or patient have severe symptoms like seizure, hypovolemia, acidosis, renal impairment, or other systemic manifestation, usually need. عادة الديفروكسامين is only bind to ferric form, intracellular iron, iron ferritin, and hemosiderin, and it's not bind to iron in hemoglobin or iron in cytochrome. It's good action. What we do if we don't have serum iron? If we don't have serum iron, we do ferromine challenge test. What is pyroxamine challenge test? Pyroxamine challenge test, we give this pyroxamine 50 milligram per kg/m and observe for change in the color of urine. If there is change in the color of urine, that patient, this means the patient need more chelating agent. Still, the color of urine is okay, or the symptoms, severe symptoms is disappear. With close observation for any side of effect of deferoxamine, like anaphylaxis, hypotension, thrombocytopenia, or optic neuropathy. If we do X-ray and still we show pills, after that, refer patient to endoscopy and gastrostomy. What the patient if anuric and renal failure, patient may transfer to oxygen transfusion and dialysis. Pills maybe as radioic pills. There is some question. Question one: iron absorbed in colon, duodenum, small intestine. Iron absorbed in duodenum. Iron absorbed in ferrous form or ferric in ferrous form. Iron transferred by transferrin, ferritin, or hemosiderin. Iron transferred by transferrin. Thank you very much. Please don't forget like. I don't need a share.